I'm going to share my screen here. All right. Well, I really want to welcome everyone tonight to our NETS Awareness Day Smilow Shares patient webinar, and welcome everybody. We're really thrilled to be able to do this specifically on this day. So I'd like to introduce my colleagues and co-speakers this evening. My name is Dr. Pamela Kunz. I'm an associate professor of medicine and medical oncology, and I'm the director of the Center for Gastrointestinal Cancers at Yale Cancer Center and Smilow Cancer Hospital. I'll be speaking tonight on NETS 101 and medical management. Dr. Anil Nagar is an associate professor of medicine in digestive diseases or gastroenterology, and he is an expert in advanced endoscopy and will be speaking about the role of a gastroenterologist for patients with NETs. Dr. Marie Robert is a professor of pathology, and she's chief of gastrointestinal pathology, and she'll be talking about understanding your NET pathology. And Dr. Gabriela Spilberg is an assistant professor of radiology and specialist in nuclear medicine and co-leader of the Theranostics program. And she will be talking about Theranostics and the evolving role of your nuclear medicine physician. So I'd like to just start off by acknowledging this special day, so NET Cancer Awareness Day. It's recognized broadly, really throughout the world. And I'd like to thank the Carcinoid Cancer Foundation and the International Neuroendocrine Cancer Alliance really for their help in establishing this day as being recognized so broadly. This was recognized by the state of Connecticut and Governor Ned Lamont just as of last year. So I will go ahead and get started and give you a brief overview. Each of us is going to speak for about 15 minutes. So we will try to have the presentations done in about an hour, and then we will leave 30 minutes for a Q&A. You are welcome to put your questions in either the chat or the Q&A function through the webinar. We are happy to answer them throughout, and we may also answer them at the end. So I like to start with this timeline really as a way to share the optimism and the hope that I have about the field. We had some early advances in the 1980s with chemotherapy, and octreotide was FDA approved then. And then it wasn't until 2011 that we started seeing other FDA approvals and approvals for imaging. And the imaging scans, copper-68, gallium-68, are listed up on top of the timeline. And then all of the FDA-approved drugs are listed below. And really, we've had an explosion of research in the last decade. And I find that really hopeful, and we'll talk about some of these. So key features of neuroendocrine tumors are listed here. The term carcinoid was coined in 1907 to describe this cancer and actually meant cancer-like. And unfortunately, we now know that these are in fact cancers and they can grow and spread. And Dr. Oberndorfer, who's pictured here on the right, was a German pathologist who was really credited for coining this term, and he contributed a great deal to the field, but we've learned so much since then. NETs can really start throughout the body. That's where they start, is called the primary site, and most commonly in the GI tract and the lungs. And most grow slowly in comparison with their adenocarcinoma counterparts. That's usually the more common type of cancer found in the intestines and in the pancreas. And somatostatin receptors, they're like a flag on the surface of the cell, is present on the large majority of the low-grade neuroendocrine tumors, and we'll talk more about that. So I like asking and posing this question, are NETs really that rare? You know, they are rare by incidence. That means the number of patients diagnosed per year, but in the yellow line is a figure indicating that the incidence is rising. This corresponds with the vertical axis on the left. And so we now have about 7 per 100,000 patients diagnosed per year, which doesn't seem very high. But the prevalence, the number of patients alive, is actually much higher than was previously appreciated. And the prevalence of NETs exceeds that of stomach and pancreatic adenocarcinoma combined. This is largely due to the slow-growing nature of this tumor compared to the adenocarcinomas. So how do we make the diagnosis? Well, first, we often use a form of imaging. One is called cross-sectional imaging. This is an example is shown on the bottom left. That's like looking at bread slices through your body. That's a CT scan. We also will use an MRI. There is somatostatin receptor imaging. This used to be with using an Octria scan, but we now have newer, higher resolution types of PET scans called a gallium dotatate or copper-64 dotatate PET. I'm going to let Dr. Spilberg talk more about that. We also will sometimes use the sort of original PET scan called an FDG PET, but that's usually for higher grade neuroendocrine carcinomas. The tissue diagnosis is critical. Dr. Nagar will actually talk a little bit about how we make that diagnosis via biopsies that he does. And this diagnosis or tissue diagnosis helps us determine the grade and the degree of differentiation. And Dr. Robert will talk some about that. We also sometimes look at hormone and tumor markers. A classic example of that is a 24-hour urine 5-HIAA. That's a metabolite of serotonin, and that's associated with carcinoid syndrome. And we have some other hormones and tumor markers that we can measure as well. I like to think of 6 key characteristics that impact treatment, and they are hormone status, whether patients have a functional or non-functional NET, and we'll talk about that, the stage and burden of disease, whether it's metastatic or localized, the grade and differentiation, pace of growth, the primary site, and somatostatin receptor status. And we'll go over a few of these, and I'm going to let my colleagues address some of these as well. So hormone status means, functional means whether patients have symptoms from a measurable hormone in either the urine or the blood, and that those symptoms are from hormone excess. So carcinoid syndrome is a really classic example. It happens in only about 10% of patients with small intestine NETs. It's associated with production of peptides and amines. As I mentioned, 5-HIAA is something that we'll measure in the urine. And it's associated with flushing, facial flushing. That's an example shown in the picture here of someone's cheeks and nose looking flushed. Can be associated with diarrhea, wheezing, and heart valve fibrosis or scarring. Patients with functional pancreatic NETs, and this occurs in about 40% of pancreatic NETs, can secrete other hormones such as insulin that can cause low blood sugar, gastrin can cause ulcers and also some diarrhea, glucagon can cause high blood sugars, and VIP stands for vasointestinal polypeptide, and that can cause diarrhea. And so the symptoms are really defined precisely by the hormone that's secreted. Non-functional means asymptomatic or symptoms not from hormone excess or unable to measure a hormone, which is quite possible. So the difference between stage and grade, Dr. Robert is going to go over in more detail, but I think talking about this difference is really important. Stage really refers to location and extent. Where is the cancer in your body? These two images are pictures of PET scans on the left. In the middle, I'm not sure if you can see my cursor, but is a picture of a pancreatic NET. And then on the right is a patient with metastatic disease in the liver. Grade refers to what do the cells look like under the microscope. And there is a WHO classification system that I'm going to, again, defer to Dr. Robert to go over, but it's these two things together really help us think about individual patients and help us tailor treatments. Dr. Spilberg is going to talk about somatostatin receptors and how we image them and how we use them for treatment. I'm just going to go over this cartoon here. So imagine that we have a group of patients. My patients are in orange and blue, and that we want to try to identify patients that have a somatostatin receptor. That is in green. We have a specific imaging tool that allows us to do that. We select out patients that have this target or the somatostatin receptor. And then we actually have a therapy that targets that receptor. This whole idea is actually really exciting, and I have a little flame on some of the slides that I think are really hot topics. And so this idea of using the same target for therapy and diagnostics, which is imaging, equals theranostics. And Dr. Spilberg will talk more about this, but I really also like to use the analogy of a lock and a key. So that think of the somatostatin receptor sitting on the surface of the cell as the lock, and then we can attach various keys to that in the form of imaging to light up like a light bulb, and in the form of therapy. So really exciting, relatively new field. So in terms of thinking of treatments for NETs, they fall primarily into four main categories. They are somatostatin analogs. They include octreotide and lanreotide. Biologics, this is everolimus. The brand name for that is Afinitor, and sunitinib, also called Sutent. Chemotherapy includes streptozotocin and also temozolomide and capecitabine, or CAPTEM is sometimes called, and PRRT, or 177-ludotate, also called Lutathera. So these are, we really borrow from all of these buckets as we think about and tailor treatments for patients. And a lot of times I'm asked, well, is there an optimal or preferred order in which we use some of these treatments? The answer right now in 2022 is no. I tell most of my patients with low grade or well-differentiated NETs that they will likely get all of these in their lifetime, but we don't currently have clinical trials that tell us if one is better to start with than another. So treatment options do, however, differ by primary site. So some of our clinical trials and thus FDA approvals are based around specific primary sites. This is just an excerpt from something called the NCCN guidelines, the National Comprehensive Cancer Network guidelines. These are used by all physicians and oncologists, I should say. I put in red here, there is a patient version of this that's very handy. This will be available to you afterwards, and you can go back and look at this, but go to the nccn.org and patient guidelines. So pancreatic NET and small bowel NET have slightly different options. Similarly, lung neuroendocrine tumors also have some slightly different options. I'm not going to go into the nuances of this, but we have really learned over time that NETs of different primary sites have different unique features. They very likely have different biology, and therefore that really explains why different treatments may work better for different primary sites. So I'm going to talk and really end with thinking about clinical trials. And clinical trials often start working in mice in test tubes. That's preclinical, but I really want you to focus on what's in the red box. Every currently FDA-approved drug has to jump through each of these hoops: phase 1, phase 2, and phase 3 clinical trials. Phase 1 trials test safety. They're often small. They use often increasing incremental doses to determine the best dose. A phase 2 trial, we know that the drug is safe, and then it's tested to determine preliminary efficacy, usually limited to a specific tumor type, and a medium-sized trial, usually 25 to 50 patients. If the drug then passes that test in phase 2, it moves to a phase 3 trial testing efficacy, and that's usually compared to something standard. The earlier clinical trials in NETs, because there were no standard treatments, often was comparing to a placebo, but nowadays in NET trials, we are not generally comparing to a placebo. It's usually compared to another active treatment, and those are usually much larger clinical trials. Patients are randomly assigned to one treatment or another. This is a busy slide, but I have a flame image on here because I am really excited and want to impart this enthusiasm to you. So really in the last few years, there has also been an explosion of new clinical trials. These are just an example of the trials that are conducted through the National Cancer Institute in the United States. So these are federally funded trials. I'd like to bring your attention to really two takeaways on this slide. So in the left red box, I'd like you to see that these have all started since 2020. So really just in the last 2 years, we have 6 new clinical trials just through the National Cancer Institute, looking at various different disease settings. So pancreatic NET, paraganglioma, and pheochromocytoma, lung neuroendocrine tumors, patients after resection of a pancreatic NET, higher grade tumors. So really a huge span. And then the second red box that's in the middle is showing you that the large majority, with the exception of that first one, the large majority are comparing one treatment to another. So we've really moved past examining placebo-controlled trials. I will make just one comment on this cabinet trial on the top that is a placebo-controlled trial. If patients are randomly assigned to the placebo and they have progression, they then are allowed to cross over and get the cabozantinib. So I think that that trial really does allow for all patients getting the cabozantinib. So how can you learn about trials? I would say your first way is talking with your oncologist and a NET specialist. They really should be your primary guide. There are institution and cancer center based websites. I listed the Yale website here. If you are closer to another institution, your institution likely has a clinical trials website. Clinicaltrials.gov is the federally funded repository. Actually, all clinical trials are required to be posted on this. It is not very patient, or I would even say physician friendly. It is kind of cumbersome to navigate. One new site that is very patient-friendly, and we have actually piloted a neuroendocrine search tool with NANETS, which is the North American Neuroendocrine Tumor Society, of which I'm president right now. We have a new effort that we linked with patient advocates and this company, Ancora. So I'd encourage you to look at that. So I have a few parting thoughts before I pass the baton to Dr. Nagar, is that I wanted us to focus on understanding a few key basic principles: hormone status, stage and grade, that primary site matters, and really somatostatin receptors are a key target. And we have made many advances in the last 10 years in terms of treatment and imaging, and clinical trials are critical to make progress in NET treatment. And I think are really reason for hope. Certainly, if any of you have been clinical trial participants, I want to thank you and encourage those of you who have not to think about that for future. So I am going to stop share and I'm going to pass to Dr. Nagar, who hopefully can share screen. And then he will, Dr. Nagar, I'll have you just pass directly to Dr. Robert.
Hi, good evening. I hope you can hear me.
Yes, Dr. Nagar, can you please put into the view mode, just to presentation mode?
I have it in presentation. Let's see. Are you able to see it in view mode now?
No. You could either go up to slideshow, or you can do it along the bottom.
No, I'm in slideshow right now, and it's showing me that it's Indians maybe. Okay. Showing me that I'm in slideshow maybe.
And now you just need to switch display, and you're almost there. If you go up to display settings and just switch that, you should be good. Because now we can, yep.
Can you see me now?
Yeah, just say swap.
Are you able to see it now?
Perfect.
Oh, sorry, I apologize. Good evening. Thank you for joining us this evening, and I want to thank Dr. Kunz and the organizers for having me here. Actually, I learned a lot in the previous slideshow. So I guess I'll first start by trying to answer two questions. What does a gastroenterologist do? And why am I, as a gastroenterologist, talking to patients with neuroendocrine tumors? We're not thought to be cancer doctors. So gastroenterologists are specialists who are trained to diagnose and treat diseases of the intestine. So that's from the esophagus to the colon and rectum, and includes the pancreas and liver. A lot of US patients perhaps have had a colonoscopy and interacted with gastroenterologists. We tend to perform endoscopy to evaluate the intestine, and some of us are trained in other types of more advanced procedures where we combine endoscopy with ultrasound or with techniques to remove pieces of intestine without surgery, certain layers of the intestine, certain growths. Specifically with neuroendocrine tumors, we work very closely with referring doctors, which is primary care doctors, and then with our pathology physicians, our surgeons, our oncologists, specifically because neuroendocrine tumors not infrequently require multidisciplinary approaches, especially patients with more complex and metastatic disease. And so sometimes patients come through and see us first and then move on, and we work with our colleagues to get the best possible treatment plan. Why should a gastroenterologist get involved with patients with neuroendocrine tumors? And the reason is, and I'm going to repeat the slide from the previous presentation, the commonest site currently for the origin of neuroendocrine tumors is the GI tract, and the GI tract is short for gastrointestinal tract. Most commonly in the gastrointestinal tract, it tends to be in the rectum, in the small intestine, and then less commonly in the pancreas and stomach. A term coined, because it's so common in the intestine, is gastroenteropancreatic entities, GEP entities. And so not infrequently, a gastroenterologist may help in the diagnosis and sometimes, rarely, in the treatment of neuroendocrine tumors. The slide was in the previous presentation, but I thought it was important enough to repeat. And what I guess the thing here is, you hear a lot, I'm sure, from your doctors, your primary care doctors, and from advertisements about screening for colorectal cancer. And it is the most common solid tumor that we see in the intestine. What is not receiving much attention, as much attention, is the fact that neuroendocrine tumors, if you take them all together within the GI tract, that means we're taking the pancreas together with the colon, together with the small bowel, is the second most common in prevalence. The previous slide presentation discussed the difference between prevalence and incidence. And so this is because of two things. It's a common tumor, and patients tend to live longer. So if you take the total number of patients with this tumor, it's actually quite common, and is slowly getting more attention. This slide is again a repeat, but it's important to look at the slide. And what we're seeing here is incidence. These are new tumors. And what we do note is new tumors are increasing, neuroendocrine tumors. This is incidence per 100,000. And within the gastrointestinal tract, we are seeing it most commonly increase in the rectum, in the small intestine, and in the pancreas. So not only is prevalence high, but incidence is increasing. And we should ask the question, why? We don't know the answer to it, but there might be some suggestions about perhaps some of the factors involved in why more commonly these types of tumors are seen and diagnosed. And one common thing is colonoscopy. It's much advertised and recommended that after the age of 45, without a family history, a patient, a male or female, should undergo screening colonoscopy or some other type of screening procedure, whether stool-based test. And as we do more of these procedures, we tend to find other tumors, not just colon cancer. And I think that is a marker of why perhaps rectal neuroendocrine tumors are increasing. We also note that what we call cross-sectional imaging, which is an image obtained of the abdomen, of the body using an MRI or a CT is much more common. If any of you have had relatives go to the emergency room, or you yourself go to the emergency room and you complain of pain, after initial blood tests, not infrequently, a CAT scan is performed. And so when we do more of these imaging, we tend to also find other things that perhaps was not the reason why the CAT scan was performed. So that's another reason why we find these small incidental tumors and sometimes larger tumors. We're also getting much better at making the diagnosis. As physicians, we recognize this more often. Our pathologists are excellent. They have a lot of various ways to make the diagnosis. Perhaps we didn't have that 10 or 20 years ago. And no doubt about the fact there are unknown factors. We don't understand why, what perhaps is the driving carcinogen or the factor that's making these tumors grow in someone's body. Is it something in the environment, diet, chemicals? We don't understand that, but that's probably another factor. So what would be the role of the gastroenterologist? And I'll try to cover that broadly in a few slides. First, we help with the diagnosis. I went over the fact that the GI tract is a common location. And so if I perhaps am doing a colonoscopy, I might find an asymptomatic small neuroendocrine tumor, as here in the picture, in a patient's rectum. Sometimes patients are sent to me for bleeding or for heartburn or for reflux. And I do an endoscopy and we in fact find a small tumor in the stomach. Other types of procedures I would perform and other gastroenterologists would perform is for a known abnormality. A scan shows something growing in the intestine, and then we follow that up with an endoscopy that tries to get to the area to make the diagnosis. And then for pancreas tumors, we make the diagnosis by doing a biopsy of the pancreas using endoscopic ultrasound, and I'll try to show you that in more detail. So we would start the process off towards diagnosis, and then the following speakers, Dr. Robbe and Dr. Spilberg, will take on the fact of once the biopsy is there, how are these tumors classified, and how that helps in tumor treatment. And you heard from in the previous slides, I think, what are these new medications for larger tumors, larger bulk of disease. In terms of treatment, what treatment perhaps could we offer certain patients in addition to just looking and biopsying and making a diagnosis? Frequently, when we find asymptomatic lesions, particularly in the stomach and the colon, they're small. And some of these can be removed through the endoscope, like a polyp is removed during colonoscopy. So that's a therapy, as it were. We also sometimes do surveillance, which is regular checks on patients at higher risk for neuroendocrine tumors. As we pointed out, with the incidence, patients live longer periods with neuroendocrine tumor. And during that time, either related to the tumor or unrelated to the tumor, chronic symptoms can develop. It's diarrhea, maldigestion, malabsorption, pain, and sometimes a gastroenterologist can help with the management of that. And ultimately, there is some emerging role that perhaps additional endoscopic treatments can be performed using things like ultrasound for small tumors. So what about presentation? That's a common question with patients, either because when we find a tumor, they say, doctor, we had no symptoms, we didn't know we had this. Other patients say that I've been having all these complaints for such a long time and it took years to make a diagnosis. And it is difficult to make a diagnosis of neuroendocrine tumors simply because they tend to be asymptomatic, number one. They also tend to grow very slowly. Very rarely they present with the classical syndrome that was outlined in the prior talk, flushing, diarrhea, and skin rash. But this is rare. Me as a physician who doesn't specialize just in seeing neuroendocrine patients will see that rarely, maybe once or twice a year. More frequently, I see patients with non-specific symptoms, and neuroendocrine tumors may be part of the differential diagnosis, but there are other much more common things. So in terms of a patient with diarrhea, there would be a lot of other reasons for diarrhea for thinking of a neuroendocrine tumor. Small intestinal tumors, though, are on the rise, and they do present with bleeding or pain or blockage of the intestine, because the small intestine is narrower and symptoms can present. And very rarely there are rare syndromes that you don't need to know about, but you might read about, such as the MEN syndrome as a presentation. And so a couple of slides on just specific types of neuroendocrine tumors, and one of them is in the stomach. These can frequently be found just incidentally on endoscopy for some other reason. So we do find the tumor, but it's unlikely that the tumor caused perhaps the pain or the bleeding or the heartburn symptom that the patient had. Sometimes it is the cause. It is associated with the chronic disease, which is called autoimmune gastritis, where there's a destruction in the wall of the stomach on the inside only, and that's the inside lining. The wall itself remains normal on the outside, and these patients make less acid, and in the process do have an increase in the cells that perhaps over time can become neuroendocrine tumors. This is a picture of small tumors, and in this setting, we can actually remove them through the endoscope. They tend to grow very slowly. They tend to have good prognosis. These patients can live a long, normal life, but we follow these patients regularly and remove the tumors as and when they grow. Certain other types of gastric neuroendocrine tumors are more aggressive and require the approaches as you saw in the previous presentation. Pancreas, the neuroendocrine tumors, and I'll repeat, they can be functional and they're non-functional. Functional means all neuroendocrine tumors make small amounts of peptides. There are certain proteins that are markers. We just still haven't, developed the technology to find this regularly in all tumors, say a blood test. On the other hand, certain tumors form specific hormones, and I'll just talk about an example of insulin. Insulin controls our blood glucose. If I have very, very low insulin levels, that would be hypoglycemia. And in hypoglycemia, I might get confused, I get a tremor. So patients who have a neuroendocrine tumor of the pancreas may secrete insulin and then come with these symptoms. So if you think about it, when they're functional, they come early because they have symptoms. These are small tumors. Sometimes we don't even find the tumor. So we get involved in trying to make the diagnosis and they can be treated, usually by surgery. On the other hand, if something is not functional, not making a hormone that's going to cause a symptom, then it's more likely that it grows silently. And so they then present with larger disease or perhaps metastasis, as you saw pictures of in the previous presentation. Here, our role is really to just make, maybe do a biopsy and then try medical management. I'll show you something about a biopsy as soon as I get past a couple more slides. I'll show you an example, if I have time, of an endoscopic ultrasound video. This is a picture of an ultrasound, which is just a flexible endoscope with a little transducer. And so we can see an image of the wall, the lining, and we can see through. And here's a picture of a CAT scan with a bright spot here, which is on the pancreas. This is the endoscopic ultrasound, where the endoscope is in the intestine. We're looking through the wall of the intestine. And here's a tumor within the pancreas. And here a needle is being placed by the endoscopist into the tumor. A few cells are obtained, and the pathologist helps us with the diagnosis. As you can see, when the needle is in something that is small, 1 or 2 centimeters, in the future, we could perhaps deliver energy through this needle, such as radio frequency energy, thermal energy, and actually treat a tumor locally, and that's being developed. In terms of neuroendocrine tumors, these are common. This is something I might see once a month at least. We have come to recognize it as we better trained. We teach ourselves to look for these small lesions. Most doctors know about them. So a lot of what happens with neuroendocrine is education, as we're doing today, education of doctors, education of patients, awareness of the disease. It doesn't look we would either biopsy it if we're not sure and then come back and remove it. Sometimes if it's very small, we can do ultrasound right there, or something there where I can cut out without making a hole and get everything else. Whereas you can see here, we can get a curative endoscopic treatment of a small neuroendocrine tumor, usually less than a centimeter. We would have to review this on pathology and make sure that it's what would be a low grade and next talk. Some of the take-home points about what I, as a gastroenterologist, can help patients who have neuroendocrine tumor stems from the fact that generally we are commonly the first specialist that you will see after either you are on a diagnostic workup for a neuroendocrine tumor, or we have found it incidentally. As I discussed earlier, the presentation of these tumors are often asymptomatic and non-specific. So there's a wide differential diagnosis, which can take time to make a definitive diagnosis. Frequently, screening exams identify asymptomatic neuroendocrine tumors. So there's much to be said about screening for colon cancer, and you should get all of your friends and relatives over the age of 45 to get screened. Endoscopy tends to be the initial diagnostic test, and that's how we get to meet with these patients and help with the diagnosis. We perform an endoscopic ultrasound to make the diagnosis. Small neuroendocrine tumors that are low grade can be removed by us, and so we have a role in therapy. We can cure them by cutting them out completely without surgery, and if they're small, you could just get into surveillance, and that's the other thing we get involved in. Once a patient has a small tumor taken out, we continue to follow them over a couple of years to make sure that nothing else grows. And we can sometimes help with treatment of chronic symptoms that develop during the long course of a patient with metastatic disease or not resectable disease. As we are on the topic here, I'm going to see if I can share another screen here. And please let me know if you're seeing this video.
Yeah, perfect.
So I'm just going to play it, and I hope it's muted. I think I did do, yes. So here is the patient I was talking about before, and this is just to tell you what's happening if you ever come to see a doctor who's, what are they doing when you're asleep with an anesthesia. Here, this is a real-time image. The endoscope is in the intestine. We're looking at the pancreas. You can see this dark spot there. That is the tumor that another doctor had seen on a CAT scan and referred the patient to us. This is our needle going into the tumor. It's all done under real time, so we know where the needle is. It's safe. It's a very safe procedure. And then when we withdraw the needle, we just get a few cells. And then we require expert pathologists such as Dr. Robert to look at this and tell us what the type of tumor is. And testing for tumor mutations is getting better and better. And we can generally achieve enough of tissue extraction in this sort of a procedure to give the pathologist an adequate sample. So at this point, I'll stop sharing my video, and I'll give the screen to Dr. Marie Robert, who's an expert pathologist in the GI tract, and she's going to talk about pathology.
Thank you, Anil, for that wonderful presentation. Can you see my screen? Is it hopefully presentation mode?
Yes, perfect.
Great. Well, hi, good evening, everyone. Thank you again for attending this evening. It's a real privilege for a surgical pathologist to speak to patients directly, and I'm excited about sharing some thoughts with you about what it is we do as pathologists that impacts a person's care. Let's see if I can do this here. So in the next 15 minutes, I hope to tell you a little bit about what a pathologist is, for those who may not, you sort of know, but you may not know in detail. And really, I want to focus on your biopsy sample or tumor resection sample. What happens to that sample when it goes into this sort of black box of a pathology lab? And what do we do with it that determines the diagnosis that we put in the pathology report? So what all the work we do, really our end result is a document that hopefully is giving all the information your clinical doctors need to treat you. Then I'm going to just dive right into neuroendocrine tumors and show you what they look like under the microscope. I'm going to share in detail how is a tumor graded And how is the tumor stage determined? And those are the two main things, as Dr. Kunz, Dr. Nagar were stating. What does this mean for the treating physicians and patients? So you've already know this, and tonight is an example of this, is that you hopefully have a team of medical professionals caring for you if you're dealing with a neuroendocrine tumor. And this is just on the physician side, gastroenterologists, diagnostic radiologists, oncologists, surgeons, pathologists, therapeutic radiologists, and others, and then a host of other medical professionals. I will share what is a pathologist. So I am a doctor who went to residency training strictly to study disease, the tissue-based disease, and to then understand, study it, and diagnose it, so that then clinicians taking samples can know what to do next if they needed tissue to help them decide. And Winifred works in our laboratory in the background. This is the surgical pathology laboratory at Yale New Haven Hospital. And this little tray here has 3 glass microscopic microscope slides, 3 glass slides. It's processed in a number of ways to render it capable of being embedded, believe it or not, in paraffin wax like candles, and that fixes the tissue. And then we take thin slices, very thin, 3 microns, 5 microns, with a special instrument called a microtome. And it's placed on a glass slide, put through some stains that make the cells very pretty colors, pink and purple. And then that's when we get to work. So there's a lot done before it's ever handed to a pathologist, physician. And we then look at it under the microscope. And we have learned a language over many years of how to recognize cells and what's normal and what's abnormal. So just considering some anatomical considerations for neuroendocrine tumors, what and where are the normal neuroendocrine cells of the body? So tumors tend to start from a normal cell that then undergoes mutations, other changes, and starts to grow in an uncontrolled fashion. So we've already heard this, that the gut neuroendocrine system are cells with these neural and endocrine type, phenotype, or just type of cell, and they're dispersed throughout the epithelium, or the lining of the gastrointestinal tract, the bile ducts, and the pancreas, as well as other parts of the body. And so this cartoon here, this sort of row of this little loop here, these are a picture of individual cells lining the intestine, and each one of them has a little nucleus, and then the rest of the cell is called the cytoplasm. So nucleus and cytoplasm, and they form a row, they make a barrier between, if you're talking about the intestine, between the outside world, or what you're eating, drinking, and the inside world, your body. And a whole lot is happening there in the intestine so that you can absorb. One of the things that happens is that you have neuroendocrine cells secreting peptides that help you absorb food and help you with insulin and glucose management and all the normal physiology and metabolism of the body. So if these cells undergo a change, by acquiring mutations or other genetic abnormalities, they can start to grow and break through the boundaries of where they're supposed to sit nice and quiet here and start to invade other tissues. And I'll show you that. So neuroendocrine tumors, when I'm going to describe well-differentiated or high grade, they grow, they tend to be somewhat slower growing than other types of tumors, as Dr. Kunz mentioned, adenocarcinoma. But others of these neuroendocrine neoplasms can grow faster. So if we want to just consider this cartoon of the anatomy of the internal organs of the abdomen, the liver is in the upper right-hand corner. It's a very large organ. And here coming through, here's the esophagus in the background. This would be the stomach, the duodenum, the rest of the small intestine, very numerous loops, just really feet and feet of small intestine. The colon, the appendix is here, and then in the background, we can't really see the colon anymore. But underneath and sort of attached to the duodenum and sitting sort of tucking under the stomach is the pancreas. So this is where the action is for tonight's discussion of neuroendocrine tumors. What does a neuroendocrine tumor look like under the microscope? So as I mentioned, it's the growth of these normal, quiet, just little inconspicuous neuroendocrine cells outside of their normal boundaries. How does this happen? Well, the cells divide and then they form growths and solid sort of nests and nodules and sheets that push through normal tissues. So here is an example here on the upper right of these pink and purple stains. This is our normal preparation of a section of the small intestine, to take my word for it, from a resection. The surgeon took out a tumor, a neuroendocrine tumor of the small intestine in this patient. And what I'm just going to point out here is that on this side, there are some sort of little finger-like projections sticking out. And this is, this is a low magnification view. This is the normal. And then all this more blocky stuff of sort of a darker pink blobs, this is tumor. This is neuroendocrine, well-differentiated neuroendocrine tumor infiltrating from the tip top of this is where the inside of the gut is, called the mucosa, all the way through the wall of the intestine. And I'll show you a cartoon of that, what that intestine wall looks like. These are just some special testing that we do that identifies cells and this one in particular is called a somatostatin stain. You heard about somatostatin receptors, and lo and behold, these tumor cells have somatostatin receptors. So we want to think about the layers. I'm going to really get into tumor staging and grading and just try to help visualize what's happening inside the body. And so a useful thing to know is that the intestines are sort of a long tube, whether you're talking about the esophagus or the stomach is sort of a fatter, more open tube, and then it closes down again and forms a tube of the small intestine and large intestine. And it's a highway. So, food is going, nutrients are going through, there's the exchange between the what's in the lumen or the opening and your body, nutrients coming in and out. The flora, the microbiome, which gets a lot of talk these days, is resident living there. And that's all in what's called the lumen, basically the hole where the food goes. Then there's a mucosal layer, then what's called the submucosa, and then a very strong muscle coat in 2 layers. And that's the muscle coat is what performs peristalsis or moves food contents along down the gastrointestinal tract. Then there's an outer coating of connective tissue. And all of this is supplied by blood vessels that go in and supply blood, and veins, so arteries and veins that leave. And this is going to be important when we talk about how tumors spread, and also a network of nerves and another type of vessels called lymphatic channels. So when we're going to talk later about staging, we're going to talk about, did the tumor, is it confined to the mucosa, the submucosa? Does it get into the muscle coat? Does it go through the muscle coat? And you can see it from what we call the serosal surface. This is where the tumor part of staging, this is what it is talking about. Going to the upper GI tract again, just another cartoon of the liver here, and this is the stomach and the pancreas and the small intestine curving around. And what I want to point out here is that you may know that if a tumor from a neuroendocrine tumor from the GI tract has spread outside and has, quotes, metastasized, the most common site of that blood vascular metastasis is the liver, and this is why. The liver receives abundant blood flow from the gastrointestinal tract because as the nutrients are absorbed, it goes directly to the liver for more activity of metabolism. And it's a fascinating way that the body works, but that also means that it's often the first site. If tumor cells break loose, they might land and start to grow first in the liver. So what's important for treating neuroendocrine neoplasms that the pathologist can provide? And that is tumor type and grade, as you've heard already. And we do tumor typing and grading at the microscope according to the instructions put forth in the World Health Organization, or WHO, classification of tumors. So there are, in neuroendocrine neoplasms of the GI tract, there are 2 tumor types, and that's all based on what we see under the microscope, and I'll show you some examples. You can have a neuroendocrine neoplasm that we use the term tumor, NET, neuroendocrine tumor, or neuroendocrine carcinoma. And you see that the root here is the same as adenocarcinoma. We talked about it as being more aggressive, and it's true here as well. A neuroendocrine carcinoma is often more aggressive. So tumor type, there are 2. Tumor, neuroendocrine tumor, or neuroendocrine carcinoma, NET or NEC. Then there is grade. Within NET, one could have 3 possible grades. And we again, by the WHO defines them, grade 1, 2, or 3. But neuroendocrine carcinomas are all grade 3 or high grade by definition. So there's actually no need for a pathologist to put in a report, high grade neuroendocrine carcinoma or neuroendocrine carcinoma grade 3. They're all grade 3. So grading and distinguishing of grading is really important in the neuroendocrine tumor category. It's defined already by the fact that you've diagnosed a neuroendocrine carcinoma in the NET category. Just some examples here, and this may seem like an abstract art picture, but these are our pink and purple pretty slides that we see, and this I'm using an example of a neuroendocrine tumor of the small intestine, a part of the small intestine called the ileum, which are usually low grade or grade 1. They can be grade 2, and only very rarely would they be grade 3. What does it look like? So I'm going to teach you all some pathology. The lumen would be here. This row here, this stuff here is the mucosa. It's normal. And then over here, those blobs again of neuroendocrine tumor. It's invading through the wall of the gut. At a little higher magnification, these cells are sort of forming rounded structures, nests, and even small glandular structures you can see over here. So it's well differentiated because it's sort of recognizable as something. It's almost a little bit like the normal. Whereas in this example of neuroendocrine carcinoma or NEC, this sample, which is a metastasis from the liver, a liver biopsy, not a resection, is just a sheet of dark purple cells. So each one of these purple dots is the nucleus of a cancer cell or a neuroendocrine carcinoma cell. And it doesn't have so much of that rounding, nesting, or gland formation. And that's why under the microscope, this is neuroendocrine carcinoma. So then once you're in neuroendocrine tumor, we do need to grade them. And how do we do that? Well, it's done by looking at 2 features, the mitotic count, and this is all at the microscope. The mitotic count, we count them, and the Ki-67 index. So the mitosis is the process by which one cell divides into 2 cells. I'll show you that. And the Ki-67 is a special stain that we use, but it's a molecule that's positive in proliferating, dividing cells and not in resting cells. So we count them, and if we're grade 1 tumors, the mitotic count is less than 2 mitoses per 10 fields under the microscope, and the Ki-67 index is less than 3%. So we actually count how many nuclei out of 100 are positive. And for grade 2, the number is higher, and for grade 3, it's even higher. So here is an example of a mitotic figure. So here's a very high magnification view of a tumor. And this funny speckled thing is a mitotic figure, and so is this. Here's two, this cell is about to become two cells, and the chromatin has doubled, and now it's separating into two cells that'll be divided right there. The rest of these are single cells with nucleon. This is a Ki67, we call it an immunostain. The brown are positive labeling Ki67 tumor cells, and we count very carefully how many of the tumor cells are positive compared to the number of tumor cells present, and we get a percentage. So here, the score was well above 20%, about 40%, and this is WHO grade 3 tumor. Tumor stage, I realize I'm going a little over my time, so I'll go a little more quickly. The tumor stage is based on 3 elements: the extent of the organ in the tumor, the T, the lymph node status, that's the node, and the distant metastasis, present or absent, that's the M. So tumor node metastasis. And for each organ in the GI tract or in any part of the body, there's a specific set of criteria. So this is the criteria for small intestine. Just by example, T1 is something that is very small, less than a centimeter. T4, it invades all the way through the gut wall, maybe into other organs. Lymph nodes are either 0, no positive lymph nodes, or maybe N1 or even more, depending on how many lymph nodes are positive. And categorized as confined to the liver or going to other sites. The T, N, and M are combined to form a prognostic stage from stage 1 to stage 4. And the easy way to remember this is that anytime there is a positive lymph node, no matter what the T stage, if there's a positive lymph node and no metastasis, it's stage 3. If there's a metastasis, no matter what the N or T stage, it is stage 4. And that's sort of the easy thing. So stage 3, you know immediately there were positive lymph nodes. Stage 4, you know immediately there were distant metastases. And I'll end with just a couple examples. So here's the cartoon of the stomach. There's a tumor here. These are the lymph nodes. They're negative. So it's a T2 and 0, stage 2. And this is just things that this is how we put it together and what we hand to your clinician. Here, the nodes are positive too. So it is an N1 stage 3. In this pancreas, the same concept. Positive nodes make it a stage 3. And in this small intestine, there's a tumor here, but there's a liver metastasis. So this is stage 4. So sorry for going a little too long, but that's what the pathologist is looking at doing with your specimen. It often takes us a few days or even a week to do everything we need to do to get the report. When we pass that information back on to your clinical team. So thank you. And later on, I'll be happy to take questions.
Thanks, Marie. Dr. Spilberg, you're welcome to take it away. And it's really fine that we're running a little bit over. We'll be sure we leave enough time for Q&A.
I'm just trying to share the screen. 1 minute, it's just giving.
No problem. I'll remind our audience that if you have questions, you are welcome to put them in the Q&A or in the chat. We can answer them throughout, but we will also try to answer them at the end.
Are you able to see now?
Yes, perfect.
Great. Good evening. Hi, my name is Gabriela. I'm a nuclear medicine physician, and I'm very thankful to be here tonight and share with you a little bit of how things are changing significantly in my field and in how it influences everyone else who's around, also in a care team approach. So I have no disclosures. So molecular imaging means, people talk about that all the time, and sometimes it's not clear. This is a type of medical imaging that provides details of what is happening inside the body at the molecular, at the cell level. So really what's happening in the cell and in the conjunction of cells rather than just an anatomical picture. So before, we used to have something called anatomic or conventional imaging that usually includes a CAT scan, MRI, and ultrasound or X-ray. These are pictures of a physical structure. So for example, here, this is an MRI. This was a primary neuroendocrine tumor of the kidney, and you can see on CT2. And then we had this new modality of imaging called molecular imaging, which really is based on positron emission tomography, which is of the body and how is the chemical reactions and the biological processes that are happening. So on the bottom here, this is a PET CT, and we'll go further into that. So how do we perform molecular imaging? We inject something called a radiotracer in a peripheral vein, just like the same way that you get a blood sample, and it's a non-invasive and painless study. You wait for a little bit. Some tracers have a different call, the pictures or the PET scan. The radiotracer is a compound which has a radioactive agent and a carrier, and this carrier has a target. For neuroendocrine tumors, the target is the somatostatin, and when a tracer is injected in the body, it travels and it builds up in certain areas depending on what is the binding target of that molecule. And again, in neuroendocrine tumors, we usually target the overexpression of somatostatin receptors, especially the type 2. So there's a couple of tracers which are approved for imaging of these neuroendocrine malignancies based on the fact that they overexpress these somatostatin receptors. So gallium dotatate was approved in 2016 by the FDA in the United States, and copper dotatate was approved a little later in 2020. A much older tracer called FDG is a glucose analog, so it really measures metabolism, is less commonly used for low and intermediate grade neuroendocrine tumors. However, for more aggressive disease or such as neuroendocrine carcinomas, it becomes much more relevant. And this is just a picture of our scanners. And then a lot of people ask, so which scan should I get? What's really better? And I don't think we have a very straightforward and defined answer for that. Initially, when copper was launched, there was some technical component that stated that maybe you would have better imaging with copper, but this trial that happened that stated that was done in Europe, and really they didn't really use gallium-68 dotatate to compare. It was some other compound. There are other compounds approved elsewhere in the world which are not available in the United States. So really, we don't have that answer that one scan is much better than other. And then copper also has remote sites where you don't have cyclotron, which means it's a big machine that generates these compounds, is available. So these tracers decay with time. So if the half-life is longer, it allows you to take them to more remote locations geographically. So I don't think at this time point it's really that relevant which tracer you get scanned, but it's really important to get imaged when there is indication for so getting appropriate staging and appropriate treatment based on your staging. So for example, in this image, do the bones look normal? And this is just a CAT scan. And you can maybe say that, you know, there's some heterogeneity of the vertebral bodies. This is a spine image. And then when you do a gallium dotatate, you can see that all these things that light up in the bone regions, this is barely perceptible in what we call anatomic image. So a lot of time see that they have a dotatate, and then have been with a long time, and they're just not seen in other modalities. So the most important thing between these two tracers when we talk about them is to keep consistency. So if you had a gallium, you should be followed up with a gallium, but if you had a copper, you should be followed up with a copper. And given the way these radio tracers are produced and distributed throughout the world, we have had periods of shortages of one or another, and we will continue to have those. So sometimes getting to therapies and getting to the information you need is more important than anything else. So there are no real big rules on those. These are generic recommendations, but none of these is really a hardcore rule that you but really it's more how I think in this field. So again, there's no head-to-head comparison, and the only comparison is from copper dotatate with gallium dotatalk, which is not the same as dotatate. And even though there was increased lesion detection, there was no difference. And evolving from that, when we can see, can we really target what we see? And that's when we call Theranostics. So Theranostics is a treatment modality that uses the power of diagnostic imaging. So we get our dotatate PET-CT, we identify the target is present, and now we know that those receptors are there. And we're going to leverage based on that information to treat these patients and these cancer cells. So assuming the target is present, which we currently use somatostatin receptor 2, then we get the same molecule that we used to image, and now we attach a radiation particle that is delivered in your vein. It's called lutetium. It's a beta emitter, which is a type of radiation, and it gets to the cancer cells binding through the somatostatin receptor. So as it binds to the somatostatin receptor in the cancer cells, it gets internalized inside the cell. So the receptor that was in the surface of the cell now goes inside the tumor itself, goes inside the cell itself. And then that's when you have the release of the radioactive particle. And this particle is what more. So with beta particles, we know that the radiation can kill the cell itself and some of the neighbor cells. So again, we can leverage on this because somatostatin receptors type 2 are known to be overly expressed in specific types of gastroenteropancreatic neuroendocrine tumors, and most of them, up to 86%, express this subtype 2, which seems to be the most common. So Theranostics really is a very individualized approach. There's a big multidisciplinary team that evaluates every single patient. No two patients ever have the same disease or picture. Even if you don't really see multiple doctors that are part of your care decision, we still always meet in the background and discuss what is the best approach to each patient in each situation. And in 2022, the approach for imaging is always multimodality. we scan with PETs, and we do dotted states. And sometimes we do FDGs too. And sometimes we do MRIs, and sometimes we do CAT scans. So we combine all of these together to try to understand what is happening and to optimize treatment into the exact patient situation. So it's very important for the imaging specialist to have access to all the imaging that's been done, even older scans that may sometimes not seem relevant. When you put a picture together of everything that has happened and how things have crossed throughout the past years, it just comes together into playing into what's the best treatment decision in each situation. So Lutathera, this radioactive therapy that's injected intravenously, was approved in 2018, and it's currently used in practice, and it's indicated for patients who have somatostatin receptor positive disease demonstrated by dotatate PET. Usually patients have 4 sessions of infusion, usually 2 months apart. The amount of radiation infused is approximately 200 millicuries, and each session lasts about 6 hours in the hospital. It starts with an early infusion of amino acids, which helps to keep the kidneys protected and the patients hydrated. Then we infuse Lutathera, really the radiation part, which is about 30 minutes. And then we infuse more amino acids to complete about 4 hours of amino acid infusion. This is the suite where the treatment happens, and it's a nice room with a beautiful view. And what is the expectation for this type of therapy in terms of what happens after you get the therapy? So it's a therapy that's very well tolerated. In the approval trial, 77% of the patients completed the whole cycle of all infusions. And from all patients treated, 18% experienced tumor shrinkage, and another percentage experienced stability. So based on this markedly longer progression-free survival in patients treated with this therapy versus just octreotide, long-acting octreotide, this was approved in 2018. And since then, we have learned a little further about things. So these are just the radiation precautions. So even though this is intravenous radiation, this is not something to be afraid about. This is something, the more knowledge you have, really, the more educated you are, and then you can be proactive about what you should do. And there aren't a lot of restrictions after getting the therapy itself. As you can see here, you stay about this half a day in the hospital, and then you go home, and then really you avoid extended time in public spaces for 3 days. And when I say extended time, I'm talking about hours, not like going minutes. And then there are other precautions that also need to happen. And we meet with patients when we go over through all of these, so everyone is aware. So what's the future really from here? Where are we going to go? So we have been doing therapies with these beta particles, but there's other types of particles. There are alpha emitters, and maybe we can incorporate them. In Germany, there have been trials of alphas and betas. You do 1 cycle of alpha and 1 cycle of beta. There are new targets being discovered, and there are new mechanisms of binding to these targets using antibodies or small molecules. There will be newer and better imaging technology being deployed in the next 5 to 10 years. There's already operational in some places in the world, something called the whole body PET, which instead of a ring, which at 25 centimeter range, we're talking about a tube with 105 centimeter range of imaging simultaneously. So this type of machine will require a much lower dose of radiotracer injected, even though the dose that we use for imaging is still very low. These images will have higher resolution and the images will be acquired faster. So we will be seeing smaller things. For example, in this picture, this little dot here was a primary tumor, and this is sub-centimeter. We would never see this in any other modality and with a prior generation of technology. And then the other question we still have not answered is, when in the disease cycle should we really start these intravenous radiation therapies? Should we really start when patients have failed other types of therapies, or should we be starting earlier? And that question has not been completely answered. And also, can we expand the use of these into other types of neuroendocrine tumors, such as lung primary or other locations? That is currently being studied. And all these questions are to be answered in the near future. And it's a very exciting and very new field that I'm delighted to be here presenting to you tonight about. So please feel free to ask any questions. Thank you very much.
Thank you so much, Dr. Spilberg. If you can unshare, and then we will, everyone, Dr. Nagar can maybe also show his picture. That would be great. And we'll take some questions. So we had a number of questions come in from the audience, and we've been all trying to kind of madly type some answers, but some of them I will call out for the team. So Dr. Robert, I wanted to just highlight one pathology question that came in, which is around, it was specifically asked about comparing NETs and prostate cancer grading and stage, but I actually think that it could really apply broadly. Do we use similar grading across tumor types, or is it unique to NETs?
Oh, that's a good question. And that's sort of the vein of the pathologist and clinician's existence, I think. So no, while there are lots of similarities, often a positive node puts something into stage 3 that is by no means uniform. And so the manual, I'm holding it up. This is the manual. It's this thick, very heavy, and every tumor of the body is included in it. And so we actually refer to it, we're GI specialists, we're only working in our area, but even neuroendocrine tumors, as Dr. Kunz is well aware, lung primary neuroendocrine tumors are graded differently than GI neuroendocrine tumors, so it gets that fussy.
Thanks, Dr. Robert, definitely. We have had a number of questions come in around Theranostics. So Dr. Spilberg, I know this is a really, as I had put in on my hot topics, kind of an area that is relatively new, emerging, changing. I will mention that we now have Theranostics for prostate cancer. So it's really just exploding in terms of treatments for other tumors outside of NETs. Can you speak a little bit more? There were some questions that came in around alpha therapy. I know you mentioned this briefly, but maybe just the difference between sort of Lutathera currently being a beta therapy and why we're excited about thinking other particles that are emitted.
So basically, Lutathera uses beta particles. Alpha particles have a lower energy and they travel a little further out. Alpha particles, they have higher energy and their traveling range is much shorter. So they potentially have a more lethal effect to cancer cells locally where they exactly bind, versus the beta particles, which not always do that, as we know that even though it's a great therapy, we don't see a lot of complete responses with beta particles. And then one of the problems is, for example, when you're using alpha particles, because their energy is so high, some of these receptors are expressed in normal tissue, so you get toxicities from them. So the strategy of using one beta and one alpha cycle is to really decrease the toxicity and get a tandem effect of both of them together, aggregated, and that's why some people are looking into the combination of them.
Thanks, Dr. Spilberg. Great. Dr. Nagar, I have a question for you. This comes up a lot. Are these endoscopic removals of small tumors really surgeries? What is the downtime a patient might expect after having an endoscopic removal of a small tumor?
With neuroendocrine tumors, the evidence suggests that patients who may have therapeutic option of endoscopic removal are those with very small tumors. And so if you look at small tumors removal, while it may be technically challenging for the endoscopist, it's really a very small area that's being removed. So we would expect it to be the equivalent of an outpatient endoscopy exam for the patient. And so if I was a teacher, I can go back to work the next day.
Great. Thank you.
Back to work the next day.
Yeah, and usually not an overnight stay. Patients usually go home.
Yes, yeah, there are many factors involved. Patient related, physician related, but and insurance related. I think if you put all of them together, then if it's an uncomplicated procedure, the patient would go home.
Great, thank you. I'll take one of the questions myself that came through. What's the difference between lanreotide and Lutathera treatment? So going back to this idea of using this target, somatostatin receptors, for imaging and treatment, the somatostatin receptor is also a target for lanreotide. It's actually a protein that attaches to the receptor. Lutathera, a really good way of thinking about it is it's like octreotide or lanreotide, the protein, except Lutathera is sort of supercharged with a radiation particle like lutetium-177. So it really uses that protein is really the key that attaches to the receptor. And we can modify that by adding different types of radioisotopes. So for Lutathera, it's lutetium-177. There are some newer alpha particle emitters like actinium-225 and lead-212. And I'm not a physicist, but I'm having to learn my physics again. But it's the particle that delivers the radiation, but the protein that serves as the key to bring it to that receptor. Dr. Spilberg, I'm going to ask you another question here. What might put you at greater risk for receiving PRRT? Prior SIR-spheres, that's another form of, it's sort of yttrium-90 radiation directed at the liver for the audience. Fatty liver, I'll add some others, kidney dysfunction. What are things that we need to really be thoughtful about in terms of patient selection?
So definitely prior radioactive therapies are a factor, because eventually a part of these therapies ends up in the marrow or in the kidneys, and there is effect of that in these other organs, which are not your target organs as we consider, because they don't really have disease. They're normal functioning organs. So there are calculations that we can do to estimate what radiation dose has already been delivered and what is really safe. Also, something I didn't include here, but is the idea that the approach of the radiation dose should be individualized by the amount of disease that someone has. Currently, Lutathera has been approved in the US as standard doses of 200 millicuries, but there are questions if people who have different tumor burdens should really upfront have higher radiation sessions, and then from there really understand what's happening and not really receive this formula that we know doesn't really work for everyone. There are there's a lot of research going into that, and they're very difficult to calculate, require structure in terms of physicists and the big team. So none of these things is done as a standalone person. We're all part of a team. This is always a team approach, and so it's always important to make sure everyone is looking. Why it's so important to come to really a big cancer center where we're used to doing these. We know how to do these. We have done them before. It's not like going to a private hospital where they are stuck or experience. Team approach is really key.
Yeah, agreed. Well, I'm going to ask each of our panelists to end with something they are hopeful about the field, kind of as a way to end the evening. I'll start just so I don't put you all on the spot. I'll give you 30 seconds. So we'll in 30 seconds or less. So I will end with saying, first of all, thank you to the audience for joining us this evening. I am incredibly hopeful about the number of new therapies that are in clinical trials. This is really the way that we advance the field. I've been in this field long enough to see patients who didn't have therapy live to see advances in FDA approvals in their lifetime. So I'm really hopeful for that. I'm going to go around my Zoom room. So Dr. Spilberg, I'll have you go next, then Dr. Nagar, and then Dr. Robert.
One thing that I'm very hopeful is the new generation of PET technology. As we get to whole body scanners, we will be able to do multi-tracer imaging in a day. So there are places where patients get a dotatate and an FDG on the same day. And I think that in the end, all tracers are great, but they all have their limitations. So if you can get more information and map things a little better, we may be able to get better results and understand better what we are treating and what we are not treating, so we can approach what we are not treating and have a more targeted approach or personalized approach. So I'm very hopeful for that.
Great.
Yes, so I think for gastroenterology, I would say two things. First is diagnosis. I'm hopeful as we are able to do things like peptides, perhaps as a screening test in the blood, or maybe microRNAs. So I think we will get to a point where we have early diagnosis, so patients hopefully don't need treatment. It's a very common disease. There's just the right time for industry to get involved. So that's one thing. And the second is, just as a therapeutic endoscopist, we are now moving, and we've actually done patients where we can do local treatment with RFA. Frequently, this is a disease of very elderly patients. We are living longer. All of us here on the panel will probably live to 100. And when we live to 100, we're going to see these tumors. And it doesn't mean we want to treat them and we want to have surgery. So I think that's where these minimally invasive techniques, where by ultrasound we'll put a little RFA and burn the tumor away, because we're going to find them. So I think that's the future.
Thank you. Dr. Robert, I'll let you finish.
Take us home. So I'm really excited about two things that have to do with tissue, and that is analyzing tissue more and more with molecular diagnostics and tumor profiling, getting to really nuanced therapeutic options specific to a patient. And also related is the ability to grade and understand the prognosis for a tumor that we're doing now with counting Ki-67 manually with a much slicker purely quantitative approaches and C7 and beyond.
Great, thank you. Great way. And so thanks to my panelists this evening for spending your night with me. Happy NET Cancer Awareness Day to the audience, and thank you for spending your evening with us. So good night.
Good night. Thank you, Dr. Kunz. Thank you to the audience. Thanks to the panelists. Very nice evening. Thank you.
Good night.